layer formation. Okay, so this is how it looks like. The germ layer formation looks like. Now what happens is it involutes from the starting. It involutes from the mid, and this is how it happens. So this stage is called neural tube formation. Neural tube formation. After the neural tube, do you see these green area? So these green cells are the most important cells. So these are called neural crest cells. Now these neural crest cells, they come off and they migrate to the different areas of the body. After that, this stage is basically called migration. Migration and interaction of these cells. Give me a second, guys. Dr. Samareen, please. Dr. Priyanka, you batch, please. Please.
सुनता रहने
ऑक्सीमीटर है ना एक
Dr. Surbhi, please mute yourself. I mean, this is something which I'm not really turning the recording on. So these are the stages of development. Now I'll tell you a very stupid story, and you need to remember this story. So once there was a lady who loved to drink. So she drank and drank and drank and drank and drank. And she drank so much that she hit her head. Hit her head on one side. Okay, you can see her vomitus as well. So the side she hit her head, it led to some deformity. Okay, so there is a deformity. And at last, you need to remember that there was a cleft as well. So there are 4 things that you need to remember. First is related to drinking. Lots of drinking, lots of. Next step is hitting your head, not the drunken head is head. The third is a deformity, and the fourth is cleft. Now you have to remember this in sequence, okay? So what we discussed in previous 2 slides, it is here. So first step is germ layer formation, okay? And the first thing in the story is lots of drinking. So lots of drinking while the lady is pregnant leads to fetal alcohol syndrome. It's not like 1 or 2 bags, but lots and lots of drinking. The second thing was hitting on the head. Hitting on the head, you need to remember it as anencephaly, means there is an abnormal head. Cephaly is head, anen is absence. So there is some problem in the head. So the next stage was the neural tube formation. The third was migration and interaction of cells. Then there was, if you remember, the third step was a deformity on the site. So deformity on site was there. So you need to remember craniofacial microsomia or hemifacial microsomia. In the next stage, formation of organ system, there was a cleft. So you remember cleft lip and palate. Next is cleft palate, and last is Cruzon syndrome. So this table is very important, and a few questions have been asked. Questions have been asked on cleft palate and hemifacial microsomia. So if you remember this table, then it would be better, because there is a chance that new questions are also asked from there. Okay. Okay, I still see a lot of people unmuted. So please mute yourself, because there is a lot of disturbance, even I can hear. So it's a sincere request from my end. Please mute yourself. Dr. Pallavi, Dr. Redmi, please. Okay, germ layer formation. So germ layer formation, you just need to remember the steps. So first is, these are the stages. The stages you need to remember, because the questions are going to be asked in which stage a specific problem occurs. So that you need to see. It is present in profit. So you don't need to worry much, because in profit everything is given. Okay. Now, this is an example of how hemifacial microsomia looks like. So, one side of the face, the microsomia is not completely, the eye level is fine in this case, but you see there is a deformity in this area. So, this is how a hemifacial microsomia patient looks like. Okay. Next, we discuss the local cause of malocclusion. What are the local causes of malocclusion? Local causes is restricted to teeth. Okay, so the most common cause is premature exfoliation. So whenever premature exfoliation, so whenever a primary tooth is lost before its date, then the malocclusion occurs because of the space loss. Okay, the next thing that can happen is prolonged retention. So what happens in prolonged retention? In prolonged retention, when the tooth is there, the deciduous teeth is there, so the permanent ka jo natural path is deflected. So natural path is deflected natural path occurs when there is a prolonged retention. What it leads to? It leads to crossbite in the anterior region. Okay, it leads to crossbite in anterior region. It can lead to crossbite in posterior region as well if the tooth retained is in the posterior region. Okay, so these are the two main local causes of malocclusion, and they lead to problems in permanent dentition. Now, how does a tooth size arch length discrepancy looks like? Okay, so this is a case of cleft. In cleft, we know that arch is not properly formed. So what happens is premolars are deflected. So premolars are deflected in this case. This is how arch length discrepancy looks like. Then next, there is a crowding in the lower incisors. When there is so much crowding in the lower incisors, then you can expect a tooth size arch length discrepancy. In maxilla, buccally placed canine. When the canine is buccally displaced or the lateral incisor is palatably displaced. Both the cases, there is a tooth size arch length discrepancy. Now, there was a question, I mean, it has been asked twice by everyone. So, yeah, so there was a question which was asked in the mandibular arch, if the via premolars deflected lingually in tooth size arch length discrepancy. And I said that it is the last to occur. So I didn't mean before second premolar. So if you remember, there was a primary canine, there was primary first molar, and there was primary second molar. And iske piche there was a permanent molar. So if you remember this, I had shown you all laterals, actually in OPG. So when the permanent canine comes, then the permanent first premolar comes, and then the permanent second premolar comes. So if there is an arch length discrepancy, so these two teeth will come normally, which will be deflected, the last tooth. So I meant this. This is why in mandibular arch, when there is a tooth size arch length discrepancy, the second premolar is deflected because in dono ka canine and premolar come earlier. Canine and premolar come earlier. Okay, and second premolar is the last tooth to come in between these three teeth. This is why second premolar gets deflected, because there is no space in the arch. Okay. Now I will discuss what happens when there is a growth discrepancy. So out of all the malocclusion, class 2 is regarded because of the growth discrepancy, and class 3 is more of genetic. Though a lot of studies, recent studies show that, let's not discuss recent studies. So, so class 2 is because of growth discrepancy. The other main malocclusion that is there because of growth discrepancy is asymmetry. When there is asymmetry of face, then you have to suspect a growth discrepancy. Class 2 is less related to genes than growth discrepancy. Basically, class 2, very new studies have shown that class 2 is mostly because of maxillary constriction. So maxillary constriction does not let the mandible grow properly. So class 2 is majorly because of growth discrepancy. Yes, there are certain cases in which there are genetic causes, like class 2 division 2 is more genetic actually. It is not class 2 division 1, it is class 2 division 2, which is more related to genes. Okay. So next is genetic causes. What are the genetic causes? Which malocclusions are genetically related? Okay, so first is class 3. Class 3 has, there are certain genes which are responsible for class 3. Class 3 is also called progressive malocclusion. Okay, because it is worsened by the growth of mandible. If the mandible grows more and more, it leads to the progressive class 3. Next, the most damaging feature of class 3 is reduced overbite. Why? Because when there is no overbite, the mandible is free to grow and class 3 gets worsened. This is why the most damaging feature is reduced overbite. The next kind of malocclusion with genetic causes is, as I said, class 2 division 2. Okay. Then deep bite is also.
चलिए मैडम से नहीं मिले ना तो
Dr. Shivangi, please mute yourself. Yeah, thank you. So deep bite is also related to genetically, dentally related. Then palatally erupted canines have a genetic predisposition. Palatally erupted canines have a genetic predisposition. Then transposition. The last is transposition. Transposition is when teeth change their position, which happens in premolars and canine and lateral incisor. Most commonly, I think it is canine and premolar. So you need to remember what malocclusions are related to genes. So they are class 3, class 2 division 2, deep bite, palatally erupted canines, and transposition. Okay. Next year we are going to Dr. Manvi has asked, we always see crossbite in class 3. No, if you remember in first malocclusion, there were PB's classification in which it first was edge to edge bite, the second was normal, and the third was crossbite. So no, we don't always see a crossbite in class 3. Class 3 is not just dental, it is more of a skeletal phenomenon. So there may be a compensation in the teeth. So we might not always be able to see a crossbite in class 3. Now, Dr. Binay has asked me, can you explain closed bite commonly seen in class 2 division 2? Closed bite means when there is complete overbite, 100% overbite, that 100% deep bite. So 100% deep bite is called closed bite. Okay, and closed bite is characterized by backward path of closure of mandible. So the bite in which there is a 100% deep bite, it is called a closed bite, which is seen in class 2 division 2. Right. Next is habits. Now in habits, you need to remember this classification. So I really cannot help you out in this. So this has been asked in exam, clean, empty, and meaningful. So you need to remember these somehow. Okay. Next, we are going to discuss what is buccinator mechanism. Now, why are we discussing buccinator mechanism is that whenever there are habits, then this buccinator mechanism is deranged and it leads to a lot of things related to all the habits. So we need to understand this buccinator mechanism. So example of habit, somebody has asked me, example of habit is tongue thrusting, mouth breathing, thumb sucking, finger sucking, putting anything in your mouth, any oral habit which is deranging the buccinator mechanism. So what is buccinator mechanism? It is that the orofacial muscles in the oral cavity region, they cancel out each other. So in the center, the forces cancel out each other. The forces are in equilibrium. So in the center is the tongue. So in the center, there is tongue. Okay. So Dr. Shinu has asked me what what is a meaningful habit and what is an empty habit. So sometimes habits are related to some other thing that we don't understand. Okay, so empty habit is when the habit is without any reason. Okay, and sometimes the habit is because of some psychological reason. Okay, so you have to see the etiology in empty and meaningful habits. Dr. Shinu, can I come back to you tomorrow, because I need to see what Klein has identified. Whatever I told you right now is according to my clinical experience. So I'll come back to you again with the examples that Dr. Klein has given, because that is what is going to be asked in exam and not really the clinical application. But I'll tell you, clinically, they have a very important role, because if you see a habit, you have to find out why the habit is there. So just last week, we had a patient 20 years of age, and she is a thumb sucker. Now, 20 is a very big age for a girl to keep sucking her thumb. So we found out that she had some psychological issues, like when she was very young, her mother did not live with her. And because of the insecurity, she started thumb sucking, and her insecurities had not been gone. So even if we give a crib, it is not going to work. We give anything, it is not going to work, because the habit has a psychological reason. So even in habits, you need to understand why the habit is there. So if it has a psychological reason or if it has another reason, you have to treat that also. So we send our patient for psychological counseling, and then we are going to start her treatment. First, her psychological thing is taken care of. Okay. So now coming back to vaccinator mechanism. So the center mein, the muscle is tongue. Okay. What tongue does is tongue pushes the teeth away, right? So tongue has to have a normal position in mouth. Next, what balances the tongue's force? Tongue ka force. So first is this vaccinator muscle, which is the cheek muscle. So this cheek muscle is there. In the anterior region, there is orbicularis oris, which has upper fibers and lower fibers. Upper fibers of lower lip, lower fibers of upper lip. So upper and lower fibers are there of orbicularis oris muscle in the front. Okay. Sides mein there is the vaccinator muscle. And at the back, there is superior constrictor muscle. So from all the sides, there are muscles which counteract the force of the tongue. Okay, or we can say that all these muscles from the outside push inside, and their force is counteracted by the muscle. Now, whenever there is a habit, the normal position of tongue is deranged. Okay, so the tongue goes to an abnormal position. So when the tongue goes to an abnormal position, what happens? The vaccinator mechanism means all these muscles from the outside, they push the maxilla inside. Okay, and you see a maxillary constricted arch. Okay, so do you understand that when the tongue position is not normal, when the tongue position is abnormal, it leads to imbalance in the vaccinator mechanism, and all these muscles, vaccinator muscles, lip muscles, basically, most importantly, is vaccinator muscle that pushes the maxilla inside, and it leads to maxillary constricted arch. Okay, so the first habit that we're going to discuss is thumb sucking. So this is the classification. Again, you have to remember this. Oral drive theory has been asked in exams, so you should try to remember a few things from this classification. Next is more than 50% of preschool children show thumb sucking. Now, this is according to one study that was done in US. I don't know what is the condition in India, but please remember this, because sometimes this question may be asked. Now, we will see what all happens in thumb sucking. So what is happening? So thumb goes inside the palate, right? And it displaces the tongue down. So the tongue is gone below, which is not its normal position. So tongue ka position is displaced. Then the thumb applies force on the upper teeth, right? And okay, these are the three main things. And it also applies force on the lower teeth. So it pushes backward. So let's write down what all can happen. Okay, you can also write in the chat box so that if I forget anything, I can see that. So the first thing that will happen is tongue position is down. Sorry, upper teeth are pushed. Upper teeth are pushed. Buccally. What all you can think of? Proclination of maxillary teeth. So upper teeth pushed buccally is the proclination of maxillary teeth. Then lower teeth are tipped. Lower teeth are pushed lingually. Very good. Lower teeth are tipped lingually. Then there is a maxillary arch constriction. Why it is there? Because tongue goes down. The buccinator muscles pushes the maxillary arch inside, and there is a maxillary arch constriction. Okay. Now, do you see, because of this thumb, the patient is not able to close the mouth? Okay. If the patient is not able to close the mouth, then the posterior teeth erupt. Okay. So there is an eruption of posterior teeth. Posterior teeth eruption is there. Then you said, somebody said lip trap. Lip trap may or may not happen, but yes, most of the times it does happen because there is an increased overjet. There is an increased overjet, and because of the increased overjet, the lip goes inside. Okay, so if the thumb is placed on one side, it can lead to asymmetry. Yes, it can lead to open bite. Posterior crossbite, yes, it can lead to posterior crossbite. So, and outside, how will the face look? The face will go for a convex shape. Okay, the maxillary arch is constricted. So this is the maxillary arch. If it gets constricted, it will not allow the mandible to grow. So mandible is also put backwards. Yes, I think you all can understand what will all happen when a thumb sucking habit is there. I'm sorry. Dr. Ishita, scissor bite may be seen. Scissor bite is basically a one-tooth phenomena. Okay, so when we are discussing about a habit, then scissor bite, I'll not say scissor bite, but no, actually scissor bite cannot happen. Neither scissor bite nor Brody's bite can happen, because Brody's bite is whole of the mandible contained inside the maxilla. So maxilla has to be broad for Brody's bite. Okay, Brody's bite will not be. Dr. Shivari said callus formation on the thumb. Yes, callus formation on the thumb is important, and that is one of the diagnostic way to see the thumb sucking habit. I'll excuse myself, please, Dr. Faisal, Dr. Shifali, Dr. Shivangi, please mute yourself. I don't know how I have just the settings are there, but still people are able to mute themselves. Okay, next is we are going to discuss the swallow. Dr. Kushak, kindly mute yourself. Dr. Manvi is asking, will the profile be convex or concave? The profile will be convex. Okay, so the next thing that we're going to discuss is this we have discussed, right? Vaccinator mechanism. And there will be open bite. This open bite will also be there. That we have all discussed. Next, this is very, very important. Somebody has asked, Dr. Manvi has asked, why the profile will be convex. Profile will be convex because the maxilla is constricted. Okay, so the mandible will be restricted to grow forward, right? So mandible will be back. So when the maxilla is constricted and the mandible is back, then when the maxilla is constricted, mandible will be back, and the profile will be like this. So this is a convex profile. Ma'am, how posterior teeth eruption would be there? Posterior teeth eruption would be there because this thumb is keeping the mouth open. Okay, so this is why the posterior teeth can erupt. They are free to erupt. There is no normal occlusion there, and posterior teeth are free to erupt. So it can erupt, and that will lead to the backward rotation of the mandible. It will lead to the backward rotation of mandible. Somebody said backward rotation. It was a very good answer. Next, we are going to discuss the infantile swallow. Now, what is infantile swallow? Infantile swallow is it is as in the name, infant, swallowing in the infant. Now, when swallowing in the infant is there, then it is normal. But when it continues to a later stage, then it becomes a problem. Okay. So, infantile swallow is when the infant wala swallow remains in the adult stage. What happens in swallowing in infants? In infants, what happens is swallowing is so mandible is stabilized by seventh nerve. Okay, it means the facial nerve. Facial nerve, yeah. So facial muscles help in the stabilization of mandible. In adults, what happened? In adults, the mandible is stabilized by the muscles of, mandibles is stabilized by trigeminal nerve, by the elevators. Okay, so it is basically a neuromuscular disorder to have an infantile swallow in adults. So whenever a question will be asked about infantile swallow, so you have to see the nerve innervation and the muscles involved. So in the infants, the elevators are relaxed. Elevators are relaxed. Okay, but in the adults, the elevators stabilize the mandible. They are not relaxed. Stabilize the mandible. So this is one very, very important thing that we need to remember. The muscle innervations, the nerve innervations, and the muscles that help the adult or person to swallow. So what is the age? What is the cutoff age? By what age? So it is actually 4 years. Till 4 years, even if there is not mature swallow is not there, then it is fine. But if after 4 years, it is considered as an orofacial dysfunction. Okay, so it is a neuromuscular problem. Infantile swallow is a neuromuscular problem. In tongue thrusting, why I am discussing this, because when there is a infantile swallow, that kind of tongue thrusting, that is a retained infantile swallow. Okay, so this is how tongue thrusting looks like. Okay, so I'll just check once again. In infants and adults. Okay, so let's go back to very simple stage. So first is there is a suckling reflex. Suckling reflex is what? This is the reflex that helps. Suckling reflex helps to suck the milk. Okay, in suckling reflex, what happens is facial muscles are used. Facial muscles are used for swallowing. Facial muscles are used for swallowing. Mandible is stabilized by facial muscles. Facial muscles are innervated by seventh nerve. Okay, but when this suckling reflex is gone and a mature swallow takes place, when a mature swallow is retained, then facial muscles are not used for swallowing. Which is useful for swallowing? Tongue is used for swallowing. Okay. So tongue is used for swallowing, and the mandible is stabilized by the trigeminal nerve. So it is stabilized by the trigeminal nerve. If the infantile swallow goes in the adults, then there is a specific that is called retained infantile swallow. Now, retained infantile swallow is a neuromuscular problem. उसमें nerve का problem भी होता है. So how you need to treat it? First of all, you need to identify that it is a stabilized का मतलब क्या है? Stabilized का मतलब होता है बेटा when you swallow. Okay, go in the mirror. I'll show you what is meant by infantile swallow? How do yeah. So I'll show you what means by normal swallow and what is an infantile swallow. So when you when a normal person swallows, then there is movement of only this region, like this. Look at my face, you'll not be able to see that I'm swallowing, okay? Once again. Okay, this is a normal swallow. What is an infantile swallow? How does an infantile swallow look like? It looks like this. I cannot even swallow. But whenever an infantile swallow is there, then there is a lot of facial muscle activity. Like this. I'm not able to show you properly, but maybe I'll record some video in the next patient where I get it. So in infantile swallow, the facial muscles are used for swallowing and the mandible is stabilized by facial muscles. In normal swallow, mandible is stabilized. Mandible stabilization hota hai. Stabilization is of mandible. And in normal swallow, only your tongue is used for swallowing and only this regions should move. The facial muscles are not involved. So if you swallow normally, then your facial muscles are not involved. In an infantile swallow, the swallowing takes place like something like that. Okay, so this is how you identify if it is a infantile swallow, if there is a problem with the muscles. Okay, you understood it? I'm so glad. Stabilization का मतलब होता है stabilization का मतलब होता है stabilization of the mandible. Okay, so this is how a tongue thrusting looks like. You need to understand that there are 3 types of, so this is what we were talking about, retained infantile swallow here. Retained infantile swallow is facial muscles are active and there is a very poor prognosis. How do you treat the patient? First of all, you need to find out what is the reason of that swallow. As it is a habit, then there may be a neuromuscular problem. The neuromuscular problem hai, you need to see if there is a problem with the nerves. If there is no problem with the nerves, then orofacial myotherapy is first you go for the orofacial myotherapy. Now orofacial myotherapy is not that common in India, but now we have just started. So there is an association foundation of orofacial myotherapy. If anyone wants to, then you should join that. Even I'm a part of that association. So orofacial myotherapy is done first. The normal swallowing pattern is treated, and orofacial myotherapy works very well if there is no muscular problem. But if there is a muscular problem, if there is a neural problem, so pehle neural problem ko solve karna. So first the neural problem will have to be solved, and then only orthodontic treatment can take place. Okay, so let's discuss about simple tongue thrust and complex tongue thrust. Simple tongue thrust. Swallowing is fine. Swallowing has no problem. Mandible stabilized by elevators means swallowing is correct. In complex tongue thrust, swallowing is a problem. Okay, in that facial muscles are active and the poor occlusion is poor. In that, in simple tongue thrust, slight contraction of facial muscles, but posterior teeth are in stable interpretation. So for all these tongue thrusts, you need orofacial myotherapy. Even in simple cases, you need to educate the patient first that how you need to swallow. You have to train the tongue first. So first step is making the patient aware that he's doing tongue thrusting. So once the patient is aware, then it will be very easy for you to treat. After that, first you have to normalize the position of the tongue. Then you have to normalize the position, the muscle or the strength of the tongue, the strength of the buccal muscles. Sometimes it is so intense that you need to go for some laser ablation or something. Let's not go into the treatment too much. let's just discuss what it is here. So if you remember this slide, it includes a lot of things. So first is interdigitation is there in the simple tongue twist. In complex tongue twist, there is no interdigitation in the posterior region and the whole occlusion is deranged. Now there was a question which was asked again and again and again by a lot of people on Telegram, that there was a habit, there was some habit and a secondary tongue thrust takes place. So unless and until these things are mentioned, you think you should take that it is a simple tongue thrust, because the tongue thrusting which is secondary to any habit is a simple tongue thrust. When it is a problem of muscles, when it is a problem of muscles, then it turns to a complex tongue thrust. Okay, so complex mein kya hai? It is a complex means there are two or more factors. So there are teeth ka problem and there is a habit and there are muscular derangement. So if there is tongue thrust secondary to a habit, then it is usually simple. Unless mentioned, take it as simple. Okay. Agar unko question aapko complex pe puchna hai, they'll mention something in the question. So don't use a lot of your knowledge. Just keep things simple. So there was one question which was asked. This is why I told you this. Next comes, okay, how do you identify tongue thrust? So what you do is you retract the cheeks, track the cheek with the retractor and ask the patient to swallow. So when he swallows, he'll just do like this. All the tongue will start coming in between the spaces. And this is how you know that there is a tongue thrusting habit. Okay. So you can also hear, when you take the lower lip in your hand, then you can also feel the hyperactive mentalis. Okay. Hyperactive mentalis is also there because it is a facial muscle, mentalis. You remember facial muscles, right? In anatomy lecture. So here, you must be remembering that diagram, right? So those are the facial muscles. So the facial muscles, you can feel the contraction of facial muscles. Next, we are going to discuss mouth breathing. Now, mouth breathing has three types: anatomic, obstructive, and habitual. Habitual mouth breathing is when the mouth breathing was anatomic or obstructive and the symptoms have subsided, but still the patient breathes through mouth because of the habit, then it is a habitual mouth breathing. Okay, now diagnosis, you need to see visual examination. The patient will keep his mouth open all the time and you can see the patient breathing through mouth, that is visual. Or you have to see the nares, he will be having underdeveloped nares. Next is the mirror test. You place a mirror between the nose and the mouth. If there is fogging on the upper side, the patient is a nose breather. If there is fogging on the lower side, the patient is a mouth breather. Butterfly test, you place a whiff of cotton here. If the cotton goes up, then it is a mouth breather. If the cotton goes down, if it is a nasal breather. Next is the water holding test. You ask the patient to close the mouth and keep the water inside. And if the patient is not able to keep the water in the mouth, he needs to breathe through mouth. So that's a mouth breather. So somebody asked, ma'am, deviated nasal septum. Butterfly test is that now? How long to hold the water? Usually you ask the patient to hold the water for 5 minutes. Nowadays, I ask the patient to hold the water for 20 minutes. So I ask the patient, I just give the water to the patient and I make him sit in the waiting room and I ask somebody to check on him if he is drinking the water. But yes, 5 minutes is enough. We use butterfly test. It's your wish, Dr. Ishita. If you want to use, you can use. I don't need anything to use. I can see it from the face of a patient. Sometimes the patient is mouth breather even during function, like during talking, during speaking. In fact, I was a mouth breather and I used to breathe through my mouth while talking. I am a very fast talker and I didn't take the efforts to breathe through nose. I just used to breathe through my mouth. Because of that, I had asthma for a long period of time. and a very experienced doctor told me that I'm a mouth breather. So all this time I was diagnosing patients of mouth breathing, and I myself was a mouth breather. So it happens. Sometimes the patient is unaware. You can use any test you want, but the most you would realize that these tests are only meant for just letting you know that the patient is a mouth breather. A very experienced person does not need any test. He can just identify from your face that you're a mouth breather. And mouth breathers are very, very specific. Like if you remember, if you can imagine I'll give you an example which you will all remember. Akshay Kumar. Okay, so Akshay Kumar, if you see his arches are all constricted and he has a lot of buccal corridor space, and he probably is a mouth breather. If any one of you has any contacts with him or any way you can ask him, then ask. He is like, I am like 99% sure that he's a mouth breather. So you will have that eye once you start identifying people. I did not know that people can breathe through mouth while talking, because I was doing it and I was unaware. So breathing through mouth is a very tough habit to break. Even I am having a lot of difficulty breaking this habit. When I was taking these lectures last time, a year back, I can see myself breathing in the lectures through my mouth. So I went back to this lecture and I was seeing it, and I was telling Dr. Somil that, yeah, I'm breathing through mouth, and I did not know it. So these tests don't help a lot during function. Okay, so lots of stories. Now let's get back to mouth breathing. Now mouth breathing specifically, it is called pigeon facies. Pigeon facies because your face becomes like a pigeon. The next very common term is adenoid facies. Before that, somebody has asked, Vivo 1907 has asked me, ma'am, deviated nasal septum KW के बाद mouth breathing की problem होती है क्या? Yes, it can happen. See, होती है या नहीं होती है, you have to identify by research. Only research can answer that. Nowadays, India, I don't know why Indian people don't want to see the prevalence of any condition in our Indian population. I think you guys should start doing research. You have so many good research questions, and you should all start finding these things out. So deviated nasal septum के बाद mouth breathing नहीं होती. Deviated nasal septum might lead to mouth breathing, and when you correct it by surgery, even if that breathing persists, that is called habitual. And basically what happens is ENT should collaborate with orofacial myotherapists to give this training. Western USA में तो ऐसे ही होता है, Western countries में ऐसे ही होता है. India maybe we have started doing all these things, but it is not that a lot of people don't know about it. So this question is like a lot of things would be included in this question. So there is no clear-cut answer to it. In some cases it does, in some cases it doesn't. It is complicated phenomena, and there are a lot of factors for it. Dr. Rupika Gupta, how to correct mouth breathing in adults? So, like me, a lot of people don't know that they breathe through mouth. Okay, so the first thing is to identify why a person is breathing through mouth. There are a lot of reasons to it. Okay, can I just it's awkward like not seeing you guys in. So there are a lot of reasons why people breathe through mouth, right? So mine was habitual. I used to breathe because of the habit. You need to identify the reason. If it is obstructive, okay, and you start twisting the mouth and you start giving them oral screen, it will not help the patient. So the first step in correcting mouth breathing is identifying what is the reason. Okay, so if it is a nasal septum problem, or there are adenoids, or there is some ENT other issue, so you need to correct that, right? So if you know that maxillary expansion was discovered by ENT people because they saw that a lot of people are breathing through mouth, so they thought that there is a nasal floor is less. So that is also one of that maybe also one of the reasons why the person starts breathing through mouth, because the nose is like small. So first identify the reason. Now you've identified, you would treat the reason. If there is no reason, like me, then first step is to make the patient aware that you are breathing through mouth. So awareness sometimes is very important, and sometimes it leads to like habit is corrected. If it does not help you, then the second step is orofacial myotherapy. Now this is a new thing that I'm telling you. Maybe it is not even in the articles, I don't know. But this is what I'm telling you from my clinical experience. In books, it is written that yes, you need to give cribs and all. I don't give it, and I don't think that question is going to be asked ever. So don't worry about cribs and all. So first is orofacial myotherapy, that you correct the tongue position. You see the nose, and then you give a lot exercises for breathing exercises and a lot of facial exercises so that the patient starts breathing through mouth. It takes a lot of time, from 6 months to 1 year. It takes a patient to completely switch from mouth breathing to nose breathing. I also ask my patients to like tape their mouth like this first and like this later. So this helps in reminding them that they're opening their mouth. Now, this is something that I follow. People give appliances, oral screen and all, but I feel that these methods like give better results. So it is a lot of things how you correct mouth breathing. Right now, these things, as an exam, you have to go with the textbooks. So if you're asking from a clinical perspective, then I think we should have another session on how you actually treat mouth breathing and how you answer exams. So it is like pitch roll, and you have to understand it differently and you have to answer it differently. Okay, go with the books in exam, because that is how you're going to get marks. But in reality, things are way ahead. See, when you read a book, you are essentially reading history. क्योंकि जितना टाइम लगता है ना बुक को लिखने में, बुक को प्रिंट होने में, रिविजन्स में and all, and the moment it reaches you, the time it takes to do all this process, it is already history, and a lot of literature is created. So for getting a rank, you need to go back and read. And if you want to practice, and if you want to be a very good doctor, then you have to stick to the latest trends. Dr. Manisha Kumari, ma'am, are you still a mouth breather? So if you are hearing me properly, then you see I'm breathing through nose very strangely right now, because I have recently been like diagnosed for mouth breathing, and I really have to like breathe very like it's very hard for me to breathe through nose right now, because I am a like jaldi wala. I just love to speak. So I'm not a mouth breather. I am changing, but there are certain instances when I breathe through my mouth. So yes, I am a mouth breather right now. Dr. Yogesh Sharma, adenoid tonsillectomy surgery helpful to patients switch to nose breathing from mouth breathing. See, adenoid tonsillectomy is a procedure that opens the airway. Okay, it can help the patient from nose breathing to mouth breathing if the patient wants to breathe through nose. And because I'm a patient myself, then I can tell you the real experience. It is very hard to change the habit when you are an adult. In kids, it's easy to do this. But if you're an adult, then it's very hard to change the habit. So treating a patient is a challenge. Treating a patient with mouth breathing is a challenge. No matter how easily it is written in the books, it is still a challenge. So the surgery opens the airway, and yes, it helps the patient to switch to nose breathing. But when it is a habit, we have to, give specific importance to that habit. Okay, and awareness, making the patient aware is yes, the first step. And it is still a struggle. A lot of research needs to be done, and a lot of, not a research, basically we need to start documenting a lot of cases, how you treat mouth breathing. Okay, let's not go into details. I can talk for days about my experiences. Let's start talking about adenoid facies. So this is a specific term given to patients who have long face and all. So what are adenoid facies? So there are certain features that we can see. First is narrow width dimension. So this maxilla. So Pehle I'll tell you what all features are there. Huh? So can you see this maxilla? This is deficient. So there is a deficiency of maxilla. Then there are, can you see this? So the maxilla is deficient from right here to here, all the down here. So the mouth breathing habit. Oh, I'm so sorry. What is happening? Yeah. So mouth breathing must have started very early in life. So there is a deficient maxilla. The width of there is this narrow width. Then the protruding teeth are there. Teeth are protruding. Then lips are incompetent. Okay, so these are all the features which are like totally called adenoid facies. Then still it is a historical word. Nowadays, a lot of other things you can see. There are a lot of other things that you actually focus on. So let's not there. Let's take a look. Also, anyone asked me something about adenoid facies? Could you please can you please put the question again? Somebody asked me something about adenoid facies. It is basically class 2 division 1 malocclusion with features of mouth breathing with lower tongue position. So these all we have discussed in tongue thrusting also. Sorry, thumb sucking also. So these are the external features what we see in a mouth breathing patient. Okay. Shall we move ahead? Shall we move ahead, everybody? Dr. Shivangi, please mute yourself. Okay, let's get to the questions. Yeah. Most probable cause of crowding in the lower anterior region. Prolonged retention of lower primary incisors. Oh my god. No. It doesn't happen. Other lower primary incisors are prolonged retented, then there will be lingual eruption of incisors. It doesn't mean there have to be in crowding. Okay? Premature exfoliation of lower primary. Premature exfoliation. It is not the reason of lower crowding. The crowding in lower is the reason is tooth size arch discrepancy. मैंने आपको photos भी तो दिखाई. I showed you the photos also. No, there was lower incisor crowding. A lot of crowding was there. Yeah, it is the tooth size arch discrepancy. I showed you the photos specifically for this question actually. Okay, next. The patient is involved in mouth breathing. Clinical examination of the patient feels. Why not 2, ma'am? Okay, premature exfoliation of lower primary incisors. This will delay the eruption of lower teeth. Okay, it will not lead to crowding. It will just delay the eruption of lower permanent teeth. Yeah, the patient involved in mouth breathing, it has a convex profile. Yes. Long face. Yes. Narrow arches. Yes. So the answer is 1. Very easy. This is an easy question. This is also called R, adenoid facies. Okay, I'll just share one more thing. One more thing. So I'm a mouth breather. Do I look like adenoid facies? No. Why I'm showing you? Because I'm the best example. So what are the features of a mouth breather which will be present in a person like me also? So first thing is the palate. The palate is high arched. The palate is going to be high arched. Next, you're going to see some contraction in the premolar region, specifically in the premolar region. Look, my smile is very nice. See, nice smile. But if you see clearly, if you see closely, then here, this region is constricted. So mouth breathers, there is a maxillary arch constriction, specifically in the premolar region, and they have a high arch palate. These two things are like invariably present in patients with mouth breathing. So you can actually close your eyes and just focus on 2 things. You will find this thing. Even if my smile is great, See, it doesn't feel that there is a constriction, but if you see closely, there is a constriction in the premolar region. Just see my canine and the premolar. See here. So these two things, the maxillary arch constriction and the high arch palate, these are two features which will help you identify a patient of mouth breathing. Now this is the clinical experience of very experienced doctor, very experienced doctor. This is not me. This is Dr. Heda. He's an amazing guy. And if you ever get hold of his book on occlusion, then you should consider yourself lucky. He has written this, he has made this video book on occlusion. And if you ever go to practice dentistry, then you should read his book. Like you should listen to his book. Okay. Next question. The most common local cause of malocclusion is? Guys, lots of fun. I can understand lots of fun is happening on your end. Somebody asked a question. I'm going to get to that. Still crowding can occur if eruption is late also. Eruption is late, crowding can occur. Yes. So, what is the most common local cause of malocclusion? Yeah, the first thing that I talked in this lecture was this only. No, not like local cause. So first thing is premature exfoliation of maxillary centrals. Yeah, this is name of the doctor. He'll not help you crack the exam. This is not going to help you crack the exam. So, book on occlusion. Actually, it's a video book. Okay. And this book is not for MDS, not for MDS. So, anyone who's like, I'm sorry, but I've just gone there because it just came out. He was the person who identified me, who diagnosed me of mouth breathing. This is why I'm in awe of that doctor. So I mentioned his name. Okay, so most common cause of local cause of malocclusion is premature exfoliation of maxillary central incisors. Now this is from a book, and you have to remember this. If you ask me, what is the most common local cause of malocclusion, then the correct answer would be caries. Okay, but I have not published it, so don't go with this answer. Okay, why not to prolong retention of primary teeth? Yeah, it can, Dr. Dasmeen, it can cause malocclusion. Okay, but it has not been reported by anyone, and nobody has written in the books. This is why this answer is not correct. If you ask me sincerely, like this is my sincere explanation. Because people have not reported it to be the most common cause of local malocclusion. This is why it is not the answer, but it can definitely cause malocclusion. Definitely this can cause malocclusion, but it is not the most common local cause. And even if it is, it has not been reported. So I really cannot do anything about this. Now, Dr. Ishida, ma'am, please tell how premature exfoliation not cause crowding. If it is erupting late, but it is erupting, yes. Okay. So whenever we discuss about premature exfoliation, so in anterior region, loss of space is really less loss of space. This is why whenever we talk of lower incisor crowding, we never say that it is because of the premature exfoliation. In anterior region, there is less loss of space. Okay, this is why premature exfoliation is not the reason of lower incisor crowding. Okay. Okay, I'll just close. I'll break off. Just let us discuss these questions. There are like 5 more questions. I'll just hurry up, and you guys can go for dinner. Which of the statement is false? I'll not take any other questions right now. I'll just complete all these. Yeah, because molars are the most useful teeth for. Yes, answer is D. Which of the following is not a feature of simple tongue thrust swallow? Now, this is a very good question. Is not, okay? Just remember, except and not should be given special consideration. Yeah, teeth apart swallow. Isme na teeth apart swallow means posterior teeth, okay? So you are understanding that. Yeah. In a child, diagnosis of tongue thrusting is made by how? So I told you, you hold the lower lip with your hand and then you ask the patient to swallow. You can hold the lower lip or you can place a cheek retractor. Agar option mein cheek retractor hai na, you place the cheek retractor and you ask the patient to swallow, then you will see a tongue coming in between teeth, then that is also an option. Okay, agar ye nahi hai option mein and it is cheek retractor, then you can go with that option. Profile during chronic thumb sucking. This you all know. Convex and narrow. Narrow. 3. Okay. Now, a 9-year-old exhibits left, okay, easy, left maxillary central incisor in cross-bite. Supporting bone is harmony. What could have been the cause? Left maxillary central incisor is in cross-bite. It means that maxillary central incisor has come lingually. It means that there is a prolonged retention of maxillary left. Yes, thank you. Okay, we break off for 5 minutes. Right now.